G'day everyone. Welcome to the latest episode of Infection Control Matters. Brett Mitchell here. I almost said, so we're actually at the Infection Control Matters conference. Wouldn't it be good if we had an Infection Control Matters conference? But we're not. I'm at the Australasian College for Infection Prevention and Control conference in Melbourne. And we're just at the poster stands here, and Phil's with me. G'day, Phil.
Good to see you, Brett. Lovely day in Melbourne today at the ACIPC conference. And we just happened to find ourselves in the exhibition hall looking at some posters.
Yeah. So, talking about selection bias, Phil, you've got a poster you like.
I do like this poster. So the first one, it's called Improving Hand Hygiene Practices in Ibi Hospital. Ibi Hospital is a 60-bed acute facility in the Marshall Islands in the Pacific. And the first author is Lilietta Snoddy. What I like about this is that these folk in Ibi Island were lucky enough to get the Hand Hygiene Australia team over to do some education and training in hand hygiene and hand hygiene auditing based on their National Hand Hygiene Initiative that was done in Australia.
Just on that, Phil, does Hand Hygiene Australia still exist?
Hand Hygiene Australia... There is a website.
Okay. So, but we do know
the lights are on, but I don't think the lights are on. But I don't think anybody's home at Hand Hygiene Australia. But no, they do exist. Kate Ryan is the senior author on this paper,
and she's part of Hand Hygiene.
Kate's been part of Hand Hygiene Australia since the very start of it. Anyhow, what I liked about this poster was that they actually did some auditing, and after all their training, and they reported that their baseline hand hygiene compliance rate was 25.5%.
Well, that sounds realistic.
It does sound realistic, doesn't it? And after the Hand Hygiene Australia education, training, auditing, etc., was done, they
100%.
They raised the hand hygiene compliance rate to, what do you think, Brett? 120%?
I was going to say that. What is it?
No, they raised it to 50.2% after the intervention. So a significant increase. And, I like the fact that these compliance rates are probably closer to the truth than other compliance rates that we see.
That's very true.
Yep.
It's great to see some work like this going on in and support in the Pacific. Yeah. And also, there's a couple of interesting things I just noted, Phil. Alcohol-based hand rub placement improved, and I think actually that's with another 20 dispensers.
And
like we forget about those sort of simple things, and we're focused on the hand hygiene compliance rate. But some of those process measures, I know hand hygiene is process, but some of those process outcomes like dispensers in the right place, so that was good to see.
Got to have it at the point of care.
Yeah, they also found that half the sinks weren't functioning properly. That
difficult to wash your hands thoroughly if the sink's not draining properly.
So I think it's a nifty little poster. Sends a nice message, and well done to the team there.
A few simple things can make a big difference.
Yeah. Yep. Thanks, Phil. We've just stumbled across a poster, and it's called Epidemiology of Hospital Acquired Bloodstream Infections at the Royal Melbourne Hospital, and the authors kindly agreed to have a chat with us about that. So, Bravi, thanks for giving us up your time.
No worries. Thanks. It's great to have a chat.
So, tell us, what did you do in this piece of work?
Yeah, absolutely. So we know hospital onset bloodstream infections are associated with significant morbidity and mortality. At the moment, within Australia, we do quite a lot of work looking at Staphylococcus aureus bloodstream infections and also central line associated bloodstream infections, both of which are reportable to VICNIS, or the Victorian Healthcare Associated Infection Surveillance Coordinating Centre. But other bloodstream infections are not. There's been a move in the CDC to sort of look at hospital onset bloodstream infections, which encompass all bloodstream infections sort of after a 48, 96 hour window as well. So that's what we did in this study as well.
Yeah. You did it over 3 years?
Yeah, so 3 years. So from the Royal Melbourne Hospital between 1st of August 2020 and 31 July 23. And that time was selected because that's when the electronic medical record came into Royal Melbourne Hospital.
Makes things a bit easier.
It does, absolutely. And so we defined it as sort of any growth of an organism from a blood culture 48 hours or more after admission. And only the first episode per patient was counted, sort of similar to what was done with Staph aureus.
So I noticed, so you sort of had 1,200 odd unique organisms and just under 1,000 hospital onset BSIs.
Yeah.
And just talking about organisms, you were just talking about organisms there, and I noticed that Staph epi is one of the most common.
Yeah.
Did you look at whether that's actually a true infection, or did you just assume because it was... Yeah.
So that's been a really good question. So the definitions sort of proposed by the CDC look at all onset bloodstream infections as well, sort of regardless of if they're commensal or non-commensal. One of the challenges we had at this hospital is we've got quite a lot of hematology oncology patients that are sort of bone marrow transplants. So even if, they sort of had a Staph epi, which is considered a commensal in those patient populations, you're potentially more likely to treat. But even then, that's still leading to action, particularly within those patients as well, in terms of you've still got antibiotic prescribing as well.
Yeah. Phil?
I've got some questions for Barbie at the end.
Yeah, okay. Maybe, we get back to the results. Sorry, we diverged on the Staph epi thing.
Yeah. So I think probably some of the key results here is Staph aureus bloodstream infections only made up about 7% of all of the organisms identified, and only, that number of episodes as well. So our current Staph aureus bacteremia central line bloodstream infection surveillance sort of only captures a small portion of patients overall. I think the second point is the hematology bone marrow transplant patients had a lot more infections than sort of the non-hematology bone marrow transplant patients. One of the challenges or difficulties is using medical record data and sort of that high level administrative data is you can't necessarily drill down into understanding what's preventable. But I think the study, does show that with the back end, you can get a lot of information quite quickly that can then sort of direct, further infection prevention surveillance efforts as well.
And that's a really interesting point. So it's 36-ish% of all those hospital onset BSIs are in bone marrow transplant or hematology. And I wonder if that's like a point of going, okay, if you can't do this type of surveillance, holus bolus for everything, maybe there's some target places that you would want to do that in.
So absolutely. So one of the other things that the literature sort of determine is, okay, with these onset episodes, how many of them are actually preventable versus non-preventable as well. And some of the literature certainly shows that within sort of the bone marrow, hematology, immunocompromised, because they've got quite a lot of factors identified, it may be quite hard to prevent some of those patients. However, what we know is out of the 794 patients, 530 only had one episode as well. So, they came into hospital, they got a bloodstream infection, they left hospital, they weren't, admitted or had another infection during that period.
Yeah.
What can we do, particularly in that space to prevent it as well, if we know, hematology, bone marrow transplant patients are quite difficult to prevent infections in?
Excellent. Phil, what about you?
Yeah, no, I think it's really interesting. It's not surprising, I guess, to see that there's lots of bloodstream infections that aren't picked up by our surveillance systems, because our surveillance systems aren't that great sometimes. But I'm just curious, you talk about you might expand routine surveillance into this area. Is that's what you're going to do? And is that going to be a big burden on what you're already doing with surveillance?
So I think that's, sort of what we've heard from the ACIPC conference sort of earlier, yesterday was sort of the role of data, and particularly, I guess, with the electronic medical records, what you can do in the back end, certainly working with the EMR systems, is develop code to sort of pull out all of this data quite quickly and sort of, run code and get a bit of a snapshot analysis as well. I think that's just the first stage, and I think then, you can certainly direct some of your efforts and certainly talk to infection prevention control nurses, for example, to then sort of go into, certain demographics or patient groups or something like that to do some further work there.
Yeah, there was a really fascinating talk yesterday about the use of AI and how we can perhaps pull data from EMR laboratories using algorithms actually to try and save a bit of time and come up with some predictions around various things. I think that was targeted around resistance-related and clusters-related episodes. But you could see that kind of utility for this kind of work. And you need this kind of work to be able to test whether those algorithms and to inform some of those algorithms and rules that are going to underpin perhaps AI in the future.
Yeah, absolutely. And I think that's certainly where you could be going as well. And certainly there's some modules on the EMRs that can use it as well. But I think, the first steps and then just sort of demonstrating what's possible, sort of looking at all the data, linking all the different data sets together, like admissions data, microbiology data, not included here is, but like also catheter and device data as well, and sort of bringing that all together as well. We sort of hope the slam dunk almost to a certain degree with that electronic medical records, wasn't necessarily there, and sort of that's why you kind of need additional information, particularly diving into the case records and medical reviews. But I think it certainly provides a bit of a direction where to go as well.
Fantastic. Look, thanks so much for your time.
Great.
Well done on the
Thanks so
poster.
much.
Thanks very much.
Cheers.
So if you'll come with me, I've got a poster to show you over here. That was a great little chat with Bravi. Guess what I found, Phil?
Oh, you found an RCT.
I found an RCT.
An IPC RCT.
An IPC RCT, and it's a multi-centre international collaboration. Pretty tough gig getting a poster for a multi-centre RCT at this conference, but
They may have elected to go the poster route.
they might have, and I would also say just a bit of tongue-in-cheek with that, but it's also a pilot RCT. So I like this because it was an RCT, and we need a truckload more. And this is a good example of doing some pilot work to inform a bigger study, really. And in this study, they were interested in exploring PIVCs and to evaluate chlorhexidine impregnated dressings. And so this was done in Australia and in France, and they had three hospitals involved. And they just recruited patients for just around a year, just under a year. They looked at 300 patients, and they were really interested in the main outcome here was total infectious complications, which was a composite outcome of colonisation and infection and phlebitis. But anyway, what they found in the results, where they compared standard dressings versus antimicrobial dressings, there was a similar number in each cohort, around 150 in each. There was less PIV colonisation in the antimicrobial dressing. You'd hope that would be the case. 4% versus 1%. Phlebitis was 14% in the standard dressing and 18% in the antimicrobial dressing.
Interesting, isn't it?
Yeah, that is interesting. And then the composite outcome was total infectious complications, and it was 16% in standard and 18% in antimicrobial. So I don't know. To me, that's sort of saying there's not much of a difference there. Perhaps in the colonisation aspect, yes.
Yeah.
Unsurprisingly.
Yeah, not much of a difference, but it does raise the question. You need to look at this in a bigger
right.
study, don't you?
And look, that's really the conclusion here. I mean, they say the authors do conclude, and sorry, I should have talked about the authors. Bertrand Judgen was the lead author on this poster. Claire Rickard, Nicole Marsh, Amanda Cooley, and a bunch of other researchers as well. And their conclusion was antimicrobial PIVC dressings are promising and require testing in larger definitive trials. I guess they could be promising in the sense of PIVC colonisation, probably not from that total infectious complications result. But really, as I say, this is a pilot study, and the part of this was that their protocol will now inform future work, and that's why this kind of stuff's important, because you need to go and see how these things can actually get done, how these things get done. So, nice bit of work. Righto, so Phil's dragged me across to this poster comparing healthcare-associated infection data to hospital-acquired complication, or HAC data, to find the differences. And I'll let you talk about it in a minute, Phil, but just for our audience, HAC data is administrative data that is pulled as part of coding, so hospital clinical coders coding infection data. And it's being used in Australia more and more at a sort of senior national level to try and monitor what's going on around hospital-acquired infections, but it isn't surveillance. So, Phil, with that context.
Thanks, Brett. It's in a case of trying to fit a square peg into a round hole with this, but we'll... so this poster is called Comparing Healthcare-Associated Infection Data to the Hospital-Acquired Infection Data to Find the Differences. So this is...
And the name of this title is, Phil, just in case they missed it again. I've already said it. I'm joking with you. Yeah, no, I have. It's cool. Let's go.
So we're comparing the infections that have been identified by the infection control team in their standard surveillance program with that is picked up by the administrative coding under the term of hospital-acquired complication. And so...
2.5 years?
What they did was a 2.5 year period is in a 94-bed hospital, so a smallish sized hospital in Australia.
And actually, just on that, while you choke, is that is really good to see. I love to see these types of studies that can be done in smaller institutions that are actually going to provide some really important data for us. So, anyway, sorry.
That's fine, Brett. So what they found, I'll just race to the results, I guess, was really poor agreement. In fact, they found that only 10% of the HAC data and HAI data paired up were true cases. True infections.
So 90% of the HAC data were false. Positives.
Miscategorised patients as having a hospital-acquired infection.
That's pretty enormous.
You can't get too much further incorrect than that, can you?
You may as well you can may as well just pick a number out, because that just have a stab in the dark. It's so bad. And what were the infection types that were better than others with HAC data?
Well,
and worse
the largest percentage of false HACs were noted in not surprisingly, UTIs, hospital-acquired pneumonia, and aspiration pneumonia groups.
Yeah, right.
But I have also looked at this in a separate study for surgical site infections, and a similarly low agreement rate was identified there too. So no matter which way we try to cut and slice these HACs, they continue to provide incorrect data on what they call infections.
On one positive side, there was one perhaps shining light, and that was upper respiratory tract infections. They seemed to have reasonable agreement in terms of there weren't too many false HACs in that category. But but look, I wouldn't read too much into that.
My bottom line, it continues to be that HACs shouldn't be used for performance indicator data, performance outcomes, and I'll leave it at that.
Yeah, thanks, Phil. Well, Phil, thanks for joining me and having a look at some of these posters. Found some interesting ones.
As always, Brett, you do tend to find a couple of little gems in the poster lineup, so it's always good to have a good read off of them.
Yeah, I love looking at posters. So look, that's it from us from the poster round from the ACIPC conference in Melbourne.
And now we'll get ready for Professor Mitchell's presentations at the ACIPC conference.
Maybe. Thanks, Phil.
Cheers, Brett.